Mandarin in 1 or 2 sentences of the summary of that slide. Then you say next. So 马教授在Eric 教授讲完一个，他会停一下，然后你就1、2句话简单中文总结一下。Next， 然后 Eric will go move to the next. Thank you.
Okay. Understood. So then laser refractive techniques came along, like supracore, intercore, presbyond, and so on, which corrected not only the refractive error for distance, but also for near. But the problem was, of course, that, well, the crystalline lens is still in the eye. With people from 45 years and older doing laser refractive surgery on the cornea can give dry eyes. It can give contrast sensitivity loss. And then, of course, you have the laser maintenance, the cost and the shear time, because when you have to explain to your patients what it is, when you do mix and matching with laser, monovision, and so on, it's a lot of time preparing the patient before surgery. Now, the early 2000s, so about 20 years ago, I started using the Restore intraocular lens from Alcon, so the bifocal one. It has a high addition for near, but it had a lot of halos and glare. This was in contrast with the crystal lens. So the crystal lens also was introduced by Bausch and Lomb at that time, which gave us good distance vision and reasonable intermediate, but they still needed reading glasses. So the patients were not extremely happy with it. So we proceeded with a lot of caution. Maybe now the translator can translate this slide.
A moment, please. Yeah, a moment, please. 刚才 Martin 教授就说他为什么要开始做这个高端晶体。最早的时候他是做屈光手术的，主要来矫正屈光不正。但遇到一个问题呢，对年轻患者都没有问题，全视程都可以。但是对于45岁以上的矫正老式激光手术就不太好。他说的那个 supracore 或者 intracore 都是用来激光矫正老式，在角膜上做，会引起那个透明晶体，就是有透明晶体的人会引起干眼症，这种患者还是很不满意。所以2000年开始他做 Restore 晶体，但是呢，这个 Restore 晶体跟透明晶体来比呢，有很多视觉干扰现象，也不是很满意。所以他接下来 next please.
Thank you. So then the Oculentis M Plus came along, which gave us good distance and also intermediate and near. But that lens was already then, actually a couple of years later, a lot of those lenses calcified. So I stopped using the Oculentis M Plus for that reason. And then the next game changer actually was introduced by the company Physiol in 2011. It's called the Fine Vision, which was the first trifocal lens in the world. And it gave us very good distance, very good near. The intermediate was still suboptimal, I must say, but it was much better than all the lenses we had before. So nowadays, we have a lot of intraocular lenses at our disposal. Different companies use different trifocal lenses. We have the introduction of the EDOF lens and a lot of hybrid lenses. So actually what my patients want at the end is spectacle freedom. By having the experience of using the Restore lens in the beginning with high addition power and the crystalline lens, the compromises were huge. Now we still have compromises to deal with. I mean, you have to explain it to your patients before doing the surgery, but most of my patients will go for spectacle freedom, and they want to, when they know their compromises, they don't mind having those compromises when they are free of glasses. So please, you can interpret my slide.
OK， 所以他是最开始就开始选择多焦晶体，最开始选择的是欧蓝的 M Plus 这种晶体，但由于这种晶体的近视力和中间视力不太满意，而且会出现钙化，所以他现在已经停止使用了。 最大的变化是在出现了三焦晶体，2011年的时候有这个 Five Vision 这种，虽然中间视力还不是太满意，但是已经比较好的效果。那么最近呢，由于有这种各种技术的这三焦晶体，EDOF 晶体，还有各种混杂技术的呢，已经使患者收到了比较满意的效果，尽管还是有一些妥协，有一些折中，但是要比最早的那个 Restore 要好得多。经过良好的术前沟通，他大部分的患者都是非常满意的，而且获得了术后的无镜不用戴眼镜的这种状态。Next, please.
Okay, thank you. So where am I now in my practice? I'm using different lenses now to better understand it. We explain it to patients, like what do they drive at night? Do they read pre-operative examination and understand before choosing the right lens? Now, very recently, a new kit is around the block, a new phakic lens, the EVO Viva ICL. I did the European multicenter study. We started a couple of years ago. And this study was published in Clinical Ophthalmology in here. We're now putting together actually around the world because we are fine-tuning our protocol with this lens. So the big advantage of this technique is that we do not touch the cornea. We do not take out the crystalline higher order aberrations in it. It is a balance between plus positive, so to get that near vision. Again here, very important, we have to tell patients that it's not the same as the spheric ICL to correct astigmatism, to correct myopia and or hyperopia, because when you use these lenses, the next day the vision is very crisp, very sharp, and the recovery is fast. It's only one day, and they're very happy with the result. With this, when you have a presbyopia correction, it takes time for the brain to realize what that lens can mean for the vision for that patient. So it takes a couple of months before the brain is adjusted to the presbyopic correction in these lenses. The big advantage of this is that it is removable, so it is reversible. So even when the patient is not happy with the side effects, with maybe contrast sensitivity loss in the dark, you can take the lens out and you end up in the same state as preoperatively. So again, I would like to stress that most of our patients are only happy when they can get rid of glasses. Compromises are there. They need to understand it before going into surgery. And at least in my practice, they want to get rid of reading glasses, and they will not go for that compromise that they still will need reading glasses in most of the time during the day. So thank you very much, and you can translate this slide, please.
那现在呢，就是 Dr. Merton 的临床实践中呢，他是采用不同的人工晶体，经过详细的术前检查，为不同的患者选择不同的晶体来适应他的术后需求。最新的一个他的临床实践呢，就是一种新型的眼内有晶体眼的IOL， 这叫 EVO Viva， 它也是用老式矫正的。这种它就不用在角膜上做，而且还保留透明的晶体，所以患者都是很开心的。术后第二天能获得很好的视力，而且这个呢它是可逆的，有点像 ICL 一样。你如果是患者真的是对一些视觉症状不满意，还可以拿出来，还回到最初的状态。所以呢，经过他这些临床实践呢，目前来说，他大部分患者都是对于这种术后不依赖于视镜读书眼镜 reading glass， 他就都很满意。下一 next please.
So in conclusion, we can say that there is a high demand, especially in the COVID times, where people are wearing a mask. First of all, and yeah, it dampens your glasses when you go outside. And people, they want to spend some money on themselves. They want to spend some some energy and money on themselves because because of these COVID times, they realize that you can go on a holiday, but after you come back after 2 weeks, you still are in your routine. So they want to treat themselves with something special. Maybe there are too many different IOLs for the moment. It's very difficult for an eye surgeon to choose which lens to use. So I think we need to come up, and Sheraz Daya is working on a new classification for those advanced technology IOLs to make it simpler, not only for the eye surgeon, but also for the patients to understand what a specific IOL can mean for them in real life. So I told you already, my patients will go for permanent solutions and not for still needing glasses after surgery. And spectacle freedom is the #1 demand in my practice nowadays. And because of the demographics, because of the baby boomers getting older and older, the demand for intraocular lenses will rise in a significant percentage the upcoming 10 to 15 years. I thank you very much for your kind attention.
总结来说，就是在临床中，而且就是现在有对这种多焦晶体有高需求，就是比如举例子，现在我们叫全球大流行的这个 COVID-19， 戴口罩，然后患者不能人群不能外出度假什么，所以说他们一个是要摘镜的需求，因为戴眼镜戴口罩就不方便，还有呢，因为没有别的花销，所以会更喜欢给自己一点更好的东西。然后这些晶体有很多选择，所以说呢，还需要医生、外科手术医生做一个客观做一个根据患者实际需求来做选择吧。总的来说呢，就是这个不用戴眼镜对患者来说是一个很好的结局。然后呢，当然没有一个永久的解决方法，总是在不断的有下一步的进展。基本就是这些，谢谢大家。
谢谢。
I stop sharing now. Yeah.
Thank you, Professor Martin. Thank you, Professor Ma. We have our next speaker, Dr. Professor Francisco Carons. And Francisco, your presentation slide all have Mandarin, yes, correct?
Yes, correct.
Wonderful. 林教授，咱们就他讲完以后 when Professor Carons finishes his entire presentation, if you don't mind, 林教授你就 summarize 一下比如说2分钟总结一下他总的意思。So what we'll do, Francisco, is when you finish the entire presentation, then Professor Lin will summarize the gist of your presentation. And finally, Francisco, if you don't mind, use your cursor to point at the line that you're speaking at each moment to help Chinese audience understand. Thank you.
I will do. Whenever you are going to let me, okay, perfect. So I'm going to share my presentation right now. And let me take this opportunity to thank Ming Wang, obviously, from IR, as well as Arthur for inviting me to present my practice as regards the advanced technology IOLs and the meaning that they have to me as a cataract refractive surgeon. Moving to the next one, here we are. Here are some financial disclosures that I have to make. I consult for these companies, of which a lot are involved with the presbyopia correcting IOLs. Let me start with some very easy assumptions to make on what are advanced technology IOLs, at least in my mind. Advanced technology IOLs are all IOLs that at least for a little bit are correcting presbyopia. What advanced technologies IOLs are not are the typical spherical aberration compensating monofocal IOLs, but as well as the toric IOLs as we consider them without correcting presbyopia. To say this in a better way, we can also talk about the range of vision that is provided by these IOLs as diopters. If we assume that a monofocal IOL provides a single focus with a little bit of extra, as we know. The enhanced single focus IOLs, and you see here some commercial names, actually increases a little bit this amount. The increased range of focus IOLs, like some names that you can read here, do it even better, providing not only a useful intermediate, but a full intermediate spectacle independence, and very often also a nice near vision. And then we have the full range of focus IOLs. Again, you see here some of the brand names that actually correct all distances, giving a full range of unaided vision correction. Here is my journey that started many years ago with the first lenses available on the market. Here you see the age, the years where something significant changed in my journey. And here in this part of the slide, you can see the percentage of advanced technology IOLs that I was implanting at that time. So as for Eric, my journey started quite a long time ago. And you see how the percentage of presbyopia correcting IOLs actually increased very significantly when moving from bifocal technologies to trifocal ones. This has already been mentioned by Eric very nicely. And when another solution like the increased the range of focus or extended depth of focus IOLs were set on the market as well. Well, by now I'm implanting somewhere in between 90 to 95% of my IOLs as presbyopia correcting ones. And here is the portfolio that I offer to my patients. You can see that as regards monofocal IOLs, either toric or just spherical, I don't have a lot to differentiate. So I just have one brand. But when we are dealing with presbyopia correcting IOLs, actually, I really like to assess each single patient with what is most adequate, most related to the patients as regards the focus curve and as regards the expectations as they have. So you see here the brands and the types of lenses that I'm implanting to correct presbyopia. Of this number, 68% of the IOLs that I'm implanting to correct the presbyopia are actually toric. So how to deal with advanced technology IOLs? I really think that the journey starts from the mindset and the mindset. And the mindset should not be that one of the surgeon only. The mindset should be the same all over the practice, meaning involving the staff, the marketing system, the community you're dealing with, and obviously, and finally, the patient as well. So what is an AT-IOLs oriented mindset practice? If we consider, as we said, that advanced technology IOLs are those increasing the range of vision, we have to say that in a perfect world where price, meaning cost and performances, would not be an issue, we would only implant advanced technology IOLs. So we know that the limitations are costs and performances. But in my practice, in an advanced technology oriented practice, I think that each single patient should earn a chance to receive an advanced technology IOLs unless it is proven differently. So it's always not a matter of upgrading patients. It is more a matter to downgrade those who are not suitable to receive a presbyopia correcting IOL. But at the same time, we know that not all patients nor all eyes can receive this type of IOLs, but definitely all the patients must receive their best personalized solution, even if it is a monofocal IOL. So this is why I'm saying we like to really build the best program, the best approach for each single case. Again, I'm going to give you a comparison in between what a practice mindset is when not oriented to premium IOLs or advanced technology IOLs or oriented to them. So when you are not really oriented, you do a patient selection. If your practice is oriented, you do an IOL selection instead. You include the patient to advanced technology IOLs with a non-oriented practice while you exclude them when you are oriented and your team is as well. As regards the exams that you're running to diagnose the patients, a practice that is not fully into the advanced technology actually performs a few exams to have a consultation, and then they consult and they convert the patients to premium. In practice that are oriented, all the diagnostics are run first, so to be able to consult the patients with the knowledge that they can have presbyopia correcting IOLs and not upgrade the patients. As well as the staff members who are dealing with the patients in a practice where there is a lot of orientation to correcting presbyopia, the entire staff knows about them. The entire staff knows how to deal with it, starting from the phone receptionist down to the surgeon. And a practice where the the advanced technology IOLs are implanted in a significant way, do not focus on advantages and disadvantages. They focus more on the value that derives from choices that may bring advantages to the patients. And if costs are barriers when dealing with practices that are not really, that do not really have a practice mindset oriented to advanced technology IOLs, well, costs are opportunities when you're dealing with these kind of technologies. And then you have to know your advanced technology IOLs, because as you can see from this keypad, where you cannot have at the same time full spectacle independence, quality of vision, being able to read in the dark, because there are no IOLs able to provide all of it at the same time. It is very important that the focus is meeting patients' expectations. So you have to know what are you dealing with in terms of the technology that you have in your offices, because the different models of IOLs have different ways for delivering spectacle independence, as well they have different ways for delivering also the little disadvantages, especially in terms of dysphotopsia. And as I said, the expectations are the key in all of that, because it's all about perception, and the perception of the expectation gives a huge value to what is your practice in terms of that. So in the same way as the equation, financial equation, where value is benefits over costs, when dealing with presbyopia correcting IOLs, the value is obviously spectacle independence over the price, but also the other costs, so the little compromises that this choice may involve. And you see here, you can read them, a list of benefits and compromises to make the best choice. In terms of performances, there are two main points to consider. First of all, as we discussed, the range of distances that these IOLs are able to provide. And you see here the arrow goes downside, because starting from monofocal IOLs down to the diffractive, trifocal, and hybrid, you gain more and more in terms of distances. On the opposite, if you're considering the dysphotopsia profile, that is the second very important point to focus on, you see here in this case, the arrow goes exactly in the opposite way. So down from the most performing technologies in terms of spectacle freedom up to monofocal IOLs, the compromise becomes less and less. And finally, you need to know also your patients, because patients are not all the same. Here you can see a very short list. This list could have been 3 or 4 times longer of potential differences that may play a role when taking a choice for these patients. So you have to know what are the expectations and you have to meet these expectations. So the key point is that we as ophthalmologists, but our teams really need to understand from the patient what is the kind of benefit that really justifies and really outweighs, like in a scale, the cost, again, meaning price plus the compromises that the patient is going to pay to gain spectacle independence. So this is why it's so important to keep on interviewing the patients, spending chair times with them, interviewing maybe also relatives and friends, having questionnaires and surveys to better have an understanding of the patient's personality. And now there is also a very nice objective vision behavior monitor called Vivior, able to provide also a defocus curve of what the patients are really living on a daily basis that may really help choosing the best solution for each single individual patient. So just to conclude and summarize, the keys to provide the patients with really a complete fulfillment of each single individual need are, first of all, the mindset of the practice. As I said, everybody has to talk the same language and there must be a full commitment because spectacle independence is the greatest and biggest value that a practice performing refractive cataract surgery or a refractive lens replacement has to focus on. You have to know the advanced technology IOLs that you're going to use because from the full knowledge of their performances, you can really advise your patients about what is best for each one of them. And you have to know your patients because patients, as we said, do not have the same needs and they may give up on a compromise to have a benefit on another side that a different patient may do exactly the opposite. So the key point, as I said, is meeting patients' expectations. Thank you very much.
谢谢 ，Thank you, Professor 林教授。您总结一下最重要的，大家能够就是记住的最重要的要点。同时，希望听众们如果有什么问题，在 Chat Room 可以先把问题打进去，我们最后会有时间来回答您的问题。林教授。
好的，谢谢王院。那么Professor Francisco 呢，他跟我们分享的是这个AT-IOL， 也就是 Advanced Technology 老式矫正型人工晶体的它的一些临床应用的那么的经验。那么主要呢，他跟我们介绍的是一些它的一个思维模式，就是说使用高端晶体它的一个思维导向跟我们普通的这种思维导向呢，那么是不一样的。那么而且呢，在我们的临床实践工作当中，我们需要了解到我们每一个患者他具体的一个情况，然后呢，我们所有的晶体实际上不同的晶体它有不同的特点、不同的功能，那么也有它的一些不足之处，也就是需要我们跟我们的患者了解他的情况，然后去进行一个个性化的一个定制的一个推荐。那么最后教授他分享的就是说最后总结那么要根据我们的患者的自身需求为他定制化的选择晶体，那么思维模式是关键，然后我们作为医生要了解我们要使用的不同的这种老式矫正型人工晶体它们的特点功能一些的缺点，然后了解我们的患者，给我们的患者去定制个性化的方案，然后要充分的达到我们的患者的预期。
谢谢林教授。Next we have Professor Daya. Is your presentation?
Yes.
So Liu教授 Daya finished the entire presentation. 他讲完以后，最后总结一下。And finally, Professor Daya, if you don't mind, once again, use the pointer to point to the line that you are talking about to help the Chinese audience. Professor Daya.
Okay. Thank you. Can you unshare your screen so I can? Can you unshare your screen, please? Hello?
那个直播平台您把这个先关一下吧，谢谢。
Okay, great. Thank you. Can you see my screen?
Yes.
Great. Okay, well, thank you very much for the kind invitation to the IA group and Arthur Cummings and Professor Ming Wang. It is a pleasure to be here and to speak to you at your Lantern Festival. And happy Lantern Festival to you and the audience. So I decided to change things slightly because I knew there would be a bit of repetition, and there still will be in this slide, but it's great. You'll hear some common themes in terms of high performance lenses or advanced technology lenses. So I thought I'd do something similar, but basically, how did I get there? Why? And what do I do in 2021? So these are my financial disclosures. I work for many companies that manufacture high performance intraocular lenses. Basically, I'm a corneal surgeon, and I do cataract surgery as well as refractive surgery. I was in the United Kingdom's National Health Service for 17 years, where I directed this department, which dealt with high-risk corneal transplantation. And I also, at the same time, set up Center for Sight. We now have 3 locations in the UK. I deal mainly with refractive surgery and refractive cataract surgery, but I also deal with high-risk corneal transplantation. And we have a tradition of honoring our mentors. I trained in the United States, and I became board certified in both internal medicine and ophthalmology. Both were great educations in terms of approaching patients, disease, and any problems from first principles. The icing on the cake was working in Minneapolis, and I honor my mentors, Edward Holland and Richard Lindstrom, who taught me that it was not just about restoring vision, but giving patients the best possible vision they could get when doing a corneal transplant. Now, these were the days when we barely had corneal topography. It had just begun. I practiced in New York City and then moved to the UK, where I started very, very quickly doing refractive surgery, doing the first LASIK in the UK. And in that time, we built an organization with 3 locations, and we continue to grow. So why do I use advanced technology lenses? So the most important thing that has been alluded to already is satisfying patients. What we do is oriented around patients. And that is coupled with a demographic change that we find here in Europe and the USA, which has already been alluded to by my friend Eric Mertens. And then there's technology. All this has to balance out. What technology is available to help us satisfy patients and deal with that demographic change? And the biggest advancement, which has been an absolute pleasure to see over the last 20 years, has been lenses and also diagnostics. We need good diagnostics to get the endpoint correct. So the demographic change that's already been alluded to, this is a slide from 1980, and it's a United States slide. And the slide next to it is in 2005. And as you'll see, that the baby boomers are now in this group over here. And what we miss is is at the bottom of the slide is that actually the number of 75-year-olds that from 1980 to 2005 have doubled. And that now, 15 years on, it's getting even higher. It's growing at an exponential rate. So a lot of patients out there have cataracts. This is the United Kingdom illustrating the same phenomenon. This is 1998. This is 2008. You can see the patients are moving on, and 2018. And this is what it'll be like in 2028 and 2038. So we've got a lot of people who are getting cataracts, who are getting older, and that's the demographic that we have. So for them, many of them have already had laser eye surgery and they enjoy good vision. And now they want to retain that vision and also get rid of their presbyopia. So this is going to be a big business for all of us in time to come. Now, in terms of technology and development, clearly a lot of this development is taking place because of the audience and because of the customer base that's out there. So we want to treat a wide range of population and we want to fulfill patient desires. You've got to think about our customer. That's our patient. Presbyopia is the biggest area at this moment in time. And as I say, we've had new treatments and also new diagnostics. Now, this is a classification of lenses that has already been dealt with by by the previous speakers. Generally, the commutative lens, which is the crystal lens, there's a zonal refractive lens where different zones of the lens will will increase the range of focus. And then the diffractive lenses, which is my favorite choice, will provide a full range of focus. And then there's this terrible term called extended depth of focus, which should be increased a range of focus, as Francesco Coronis has already indicated. And there are lenses that are included in this, which he very cleverly classified in his slide. So what we talk about when we talk about advanced technology lenses is the range of focus. And it's either increased or it's a full range of focus as opposed to a monofocal lens. And I like Francesco Corona's extra component there, which is a enhanced single focus lens or improved single focus lens. And we should probably include that. Then there's how do these things work? And how do these lenses work matters, because that influences the dysphotopsias that they're likely to get. Now, I have to say that I don't believe that dysphotopsias are a big problem, because I tell my patients what to expect in advance. And once they understand what to expect, they get on with it. And in the majority of cases, it goes away. So this is my journey, not too dissimilar from my predecessors. I started the presbyopic correction with the crystal lens, the AT-45, which as you can see here, it went through several iterations, the 5.0 and the HD. But in the meantime, we started using we started using the restore lens, but that caused a syndrome called waxy vision syndrome and glare, and it was not very satisfactory. Patients were okay, but I had to remove some of them. A company called Acritec, which was bought out by Zeiss, had the Acrylisa lens and the Acrylisa toric, and this was just absolutely fantastic in terms of optics and correction. But these were bifocal lenses. Eventually, I used the M+ as well, and I abandoned it after 1 year because patients were not very satisfied with their vision. And I'm glad I did, because there's an epidemic of calcified lenses that are out there at the moment, which is really unfortunate. But as Eric Mertens said in 2011, 10 years ago this month, we started using the fine vision lens, a trifocal lens in the UK. And we've put in probably about 8,000 of them in right now. And we've had very, very satisfactory outcomes. We've also recently introduced the Artis Symbiosis lens from a company called Crystal Lens. And this one is also got some benefits that we can talk about at a hopefully future conference. So what do I do in 2021? Well, for me, it's, my approach is patient satisfaction. And I always present it in this particular way. Patient satisfaction is outcomes of the patient minus their expectations. So we want to deliver more than they expect. And this is what my mentor, Dick Lindstrom, told me when I was a fellow in 1991. Don't forget that, Shiraz. You've got to pitch it low, but give them really phenomenal outcomes. And they actually, what do patients want? They want everything. So I keep it simple. And I deliver a full range of focus, because that's what I believe all my patients want. In fact, they come to see me, as Francesco said, patients will, if you set yourself up as a high value, high end premium practice, that becomes the standard. And it's very upsetting for the patients and even for us when those patients are not suitable for a full range of focus lens. So I perform trifocals in 95% of my patients. In those that are not suitable, I will use a monofocal, or the Isopure, which is the enhanced monofocal or single focus lens that Francesco mentioned earlier on. And of my patients, 32% will get toric trifocals. We use a laser to do lens replacement surgery and cataract surgery, and that's adequate for correcting up to 1.25 diopters of astigmatism. Similarly to my colleagues, we use a questionnaire to find out what patients want. I want to find out if they're the obsessive compulsive type, and if they're very exacting. Some of the engineers are difficult. I have to talk to them for longer. It doesn't stop me from doing these lenses. I just know I have to spend more time with that particular patient. And we ask about their occupation, the sports they engage in, and so on. So how does one get started? This is what the audience really, I believe, wants to know. I think that in 20 years on, I suppose we were getting started ourselves and we didn't have any mentors, but there are a lot of mentors out there. And I would strongly advocate coming to see how these lenses are used, but not just what the surgeon does, the overall process of patient conversion from the first phone call, how they're counseled, watching the team at work and what they say to the patients during that journey, and then what the consultant says afterwards, what the surgeon says, and what the language they use when they talk to the patient. And then, yes, of course, observe the surgeon implanting the lenses, see what surgical considerations they have when they're doing this, and look at their technique as well. And finally, this is not to be underestimated. Every surgeon should really monitor their own data, because there are little surgeon factors that you might want to modify based on the lens that you use and optimize your outcomes and decrease that bandwidth of error. So in summary, these are the prerequisites. This is, as has already been mentioned, a team-based practice. It requires educated counselors and technicians, which I feel very fortunate to have at our centers. There are patient education tools that are very good. We use the iMaginations or Rendia from the iMaginations company in the United States. That really helps understanding. And then you've got to have good diagnostics, both topography and good biometry, and access to laser refractive surgery in the event that the outcomes are not exact. I have to say that as we've got better and better, less than 1% of our patients last year required any enhancement surgery because the lens power was not quite right, or we had a miscalculation in terms of lens calculation. So there's a lot of detail that goes into this. And I think that if a practice starts off with this with every single patient, then they're more likely to succeed in terms of outcomes, patient satisfaction. And I don't see it as conversions. I see it as giving our patients the best that they can get. Thank you for your attention. 谢谢你, and I look forward to our discussion later.
谢谢 Professor Daya。刘慧教授，你能不能总结一下 Professor Daya 的中心思想
？OK， 那么这个 Dr. Daya 呢，他主要是介绍了他准备在今年2021年如何开展他的这个功能型的人工晶体的植入方面的工作。那么他首先介绍了他个人的一个教育的背景和工作的经历。那么这个 Dr. Daya 呢，他具有角膜以及白内障和屈光这个背景，这方面的一个经验，也是这方面的专家。那么他首先介绍了一下，就是说他为什么要开展这个功能性的人工晶体植入，首先是要满足患者的需求。那么另外一方面就是说，随着人口老龄化，那么其实这个现象在我们中国也出现，就是说那一批最早做了这个屈光手术的那个人群呢，他现在也到了做白内障手术的或者是老视矫正手术阶段。那么这两方面的一个叠加呢，就会导致现在我们的白内障的患者的他其实这个需求也在不断的这个更加的就是说增加吧。然后另外一方面就是说这个技术的发展，就是从我们的老视矫正，他也介绍了多款的人工晶体，尤其是他个人推荐的是他比较喜欢用的这个衍射晶体，包括三焦点。另外就是说从这个就是说这个眩光和这个一些不良视觉现象方面呢，他也介绍了他的这个一些就是使用多焦点人工晶体以后的一些体会。同时呢，他也介绍了他特别强调了他对三焦点晶体的使用，尤其是这个 Fine Vision， 那他使用呢已经有10年的历史了。那么对于在2021年如何开展这个功能性人工晶体的这个工作方面呢，他特别强调了患者的满意度，也和刚才前面一位教授一样，当然他是列的另外一个公式，就是说这个产出和预期的一个这个比较吧，这个值的一个换算。那么他也是强调了，就是说他个人的话也是希望能在今年做更多的这个比例非常高95%的三焦点人工晶体。同时呢，他会在加强的患者满意度的管理方面特别是强调了问卷调查。另外他也强调了这个团队，就是说如果要更好的开展高端人工晶体的植入，那么我们需要更多的团队成员的参与，包括这个相关的一个谈话者，还包括我们的训练有素的一些 技术人员等等。那么他最后他有一个亮点，就是说他在植入他推荐的这个植入高端晶体的一个先决条件中呢，他提到了一个换教工具是一个 APP。那么其实这个也是给我们的中国的医生一些提示，是否可用更加形象的、生动的方法，让那个患者更就是了解在术前进行宣教，了解这个高端晶体和这个单焦点它晶体的一些区别。同时呢，他也强调了他在但因为它是涉及到他也做屈光手术，那么他也有这个屈光手术进行2次增效的一个方案。但是呢，通过他之前的一些优化，还有技术上的一些进步吧，当然这个比例已经比较低了，但是呢，也可以为我们国内的一些医生呢带来一些启示。好，谢谢王教授。
谢谢刘教授。Last presenter, Dr. will invite Professor Cummings back to give his second half of his presentation. When he finishes presentation, Professor Chen Xu will summarize. Arthur.
Thank you, Ming. I'm just going to share my screen. Here we go. Yeah, I've really enjoyed the session so far. They've been fantastic. I'd really like to thank my co-presenters. So I'm going to share my journey with how did I start and why do I continue and what are the benefits. I'm going to get through this quickly because many of these things have been said before. So these are my disclosures again. So I've been doing refractive surgery since 1994. And initially when we started, it was young myopes doing emmetropia with LASIK and PRK. Then later on, we started seeing presbyopes and we started treating them with blended vision or monovision to address presbyopia. And even later, we were treating emmetropic presbyopes by simply correcting one eye to reading vision with blended vision. As far as blended vision goes, though, is not everyone is a candidate for monovision. And there is pressure to deliver complete vision following surgery, including after cataract surgery today. And patient expectations are demanding, and that includes the ability to read after IOL surgery. We've heard Shiraz, we've heard Eric, we've heard Francesco, all saying patients really at the end of the day want to be able to read and they want that full range of vision. So how did I start? Well, when patients demanded freedom from spectacles, but were poor candidates for monovision or blended vision, AT-IOLs must be considered. I was not one of the first to do these. I listened to the experience of trusted colleagues like these on the panel and reporting satisfactory outcomes with AT-IOLs, and then started doing it. And I also, before I started the journey, I learned how to speak to patients about their expectations. I think we've heard a lot today about how to make this the best experience for patients. Make sure your biometry is good. Make sure your surgical technique is excellent and repeatable. And then informed consent is a few specific differences. What happens if a posterior capsular rupture occurs? It may be that you can't use the AT-IOL and your patient needs to know that. There's an increased likelihood for YAG laser after AT-IOLs because they simply the higher performance requires better optics. And then you need to have the discussion around dysphotopsia, as we've heard. Start with hyperopes. They tend to be easier to please, seeing as you're correcting their distance and their near vision. Always correct the astigmatism because any residual astigmatism can impact the outcome. And you need to ensure that the ocular surface is healthy. I've seen this before. I'm not going to speak about it again. It's just about speaking through the compromise and how typically the fuller the range, the more the dysphotopsia. But this is a conversation that needs to be had. I always show patients a slide like this that shows with a multifocal, you can see both far and near, while with a monofocal, you only have one of the two in focus. I also tell patients that they're going to have the potential of halos and glare around lights at night, but they need to bear in mind that the focus for distance and intermediate and near will still be good. I also tell them that over time, the brain tends to filter out the dysphotopsia. So we have very few patients who after 3 or 4 months have any complaints about dysphotopsia. And then finally, we explain to patients that they don't have dysphotopsia in daylight. It's only a nighttime phenomenon. So patient satisfaction is our top priority. That's why we do multifocal IOLs. As I said earlier, we don't increase revenue personally from doing multifocal IOLs, but we do indirectly from practice growth. And personally, it's very rewarding to know that you've provided someone with excellent vision, with complete freedom from spectacles, you're helping people achieve their potential and their personal safety is all very rewarding. And that's the reason I continue to do it. So thank you very much, Sheshe, and I look forward to the discussion.
谢谢 Arthur 教授陈教授，你能不能 summarize 一下？
好的谢谢 Arthur 教授，谢谢王教授。那么 Arthur 教授主要是简单的介绍了一下他这个开张老花或者多焦点人工晶体的一个经历。最早是为什么他开始要做这种老花手术？起由的话，实际上是由于他之前有做了很多关于我们屈光手术，然后在屈光手术的过程中发现有很多人有老视的需求，老视矫正的需求。那么 Arthur 教授一开始也尝试了过单眼视，结果单眼视的效果并不好。然后当患者不适合单眼视的效果的时候，他逐渐就是转向做晶体手术。那么这个晶体手术的经验可能来自他同事以及对患者之间的沟通，以及各种人工晶体技术的了解。那么他当然也强调了，现在如果要开展这种老视的晶体手术的话，首先要保证有一个充分的那个准确的角膜的生物测量、手术技术，然后跟患者充分的一个沟通。那么而且他也告诉我们选择患者也是很重要的，首先会从远视患者开始选择这种老视患者然后可以了解这个功能性晶体是可以改进远近视力的，同时也要注意矫正散光等一系列的问题。然后也要强调跟患者进行沟通，因为这种多焦的那个多焦人工晶体的老视矫正手术实际上也是一种妥协，它可能是患者需要牺牲部分的损失部分的视觉质量比如是会带来一部分的眩光光晕，它给我们也模拟了这种眩光光晕的一个情况。但是这个老花矫正人工晶体也是会给患者带来一些优势的。那么实际上Arthur教授的话，他实际上还表现出来他会继续使用这种功能性人工晶体，使患者达到一个老视矫正的目标。当然使得患者满意是他的一个最终目标他也相信不断的做这种老花手术，随着例数的增加，个人的经验的提升，那么也可以为患者实现更好的一个出色的那个视力，然后也可以实现患者的脱镜，然后提高整体手术的一个安全性。这就是Arthur教授的一个演讲的主题。谢谢。
谢谢陈教授。现在咱们开最后20分钟，就是大家讨论回答问题。我想请咱们2的李少伟教授能不能总结一下咱们北京2以及整个2系统咱们这个功能性人工晶体的运用的概况和一些体会，能不能总结一下？李教授。
那谢谢王教授这个还是有一些困难，因为整个集团的这个应用的情况是不是很平衡的我更多的是介绍一下我自己和北京2的。So I think it's a little bit difficult for me to introduce all the air groups situation where multifocal lens use because it's the different situations around China. So I would like to introduce some of my own experience and Beijing Air's situation. So I actually is cornea and actually it's cornea and cataract and also refractive surgery surgeons, and I started to use multifocal lens at 2000 earlier, and my first implanted lens is Restore. So my experience is I only choose the reliable multifocal lens to use to patients, and this means there's less photic phenomena problems, so we can predict the patient's results. So I only for those years about 20 years. I only use Restore and trifocal and as for some rare patients, I use a blended mixed lens, multifocal lens. So this, so we got very happy patients, got a positive response. So we keep working on this, and the patients get more and more. So our patients is about 30% patients we implant multifocal lens. most patients is very happy. And another key is we very focus on the precise measurement for IOL power calculation. It's very important for patient satisfaction.
Yeah. 李教授你能不能总结中文？
就是我觉着呢，就是我们爱尔的整个的这个白内障的体系呢，可能是各地方的情况不太一样，我不太好总结。就我个人和北京来说呢，我们做这个多焦晶体呢，主要是选择就是这个疗效比较确切的就是术后就是这个光学问题比较少的这些晶体呢，给患者选择，像 Restore 像三焦晶体这些。像其他的一些晶体呢，我们是可能选择性的应用，或者是就是说blended， 或者是就是两种不同晶体混搭的这种。所以呢，我们就是主要是要患者满意，那么我们才继续做这样的患者会越来越多。那么另外一个关键呢，我们还是做这个测量非常准确，必须测量准确了，这个术后效果才能好主要这两条经验我觉得特别重要，其他的专家的意见我们都非常同意我觉得。
谢谢李教授。马教授咱们沈阳的爱尔的一些这个经验以及你可以先讲中文，然后再用英文讲，谢谢。
好，谢谢王教授哈。我们沈阳爱尔做月呢，是我们集团第一家国际化设计的，所以相对来说，我们的患者偏高端一点，所以我们在患者教育上呢，有点倾向刚才卡洛斯卡尔内斯教授说的，我们就是高端晶体导向性。所以我们先是进行一个完善的检查，如果患者不适合安高端晶体，我倒是替他觉得遗憾，你因为我们做白内障手术once in一生只有一次，那不能选择最好的产品，其实挺遗憾的。所以说呢，我们医院的高端晶体就是这种AT 晶体的这种植入率能达到50%以上。那其他不合适的患者多半是由于疑难杂症合并一些并发症，实在是不适合高端晶体。这就是我们医院的情况。但确实我们爱尔集团这么多家医院在国内的水平是非常不一样的。我就是介绍一下我们医院的情况。Translate in English?
Yes, please.
Okay. Because our hospital is the first internationalized hospital in China now, so somewhat our patient is with a high demand of the presbyopia correction intraocular lens. So it's in our hospital we are premier intraocular lens oriented with a thorough preoperative examination. We told if he is a candidate for the AT-IOL, it's a lucky because the cataract surgery is a once in lifetime chance. So if it's not suitable for a premium lens, it's a pity. So the percentage of the AT-IOL in our hospital nearly 50%. The others is because of the complicated case. So if he is qualified for the AT lens, we choose for them, and with a thorough explanation before the surgery, most of them, almost everyone, are satisfied with their outcome.
谢谢马教授。We will start with question and answer now. 我们现在问题讨论。I will start with 2 questions for every panelist. 我先学第一个你前面2个问题。The question is, in the typical setting, presbyopia, 55 years old, reasonable expectation, everything pretty much average, your majority. What is your go-to lens? Assuming everything else fits, very typical standard average situation. What is your go-to lens? 55 years old, presbyopia. 55岁想治疗老花，你的最高选择的 lens 是什么 lens? We'll start with Arthur. What's your lens?
So Ming, with all respect, I can't answer that until I've spoken to the patient. We are all about customizing and personalizing the need for the patient. If the patient wants a full range, I'm normally speaking about PanOptics, normally, but any of the others, depending on what Vivio suggests. And if I need an EDOF type lens, then I'm normally looking at Vivity. But I can only make the decision after knowing what the patient's needs are.
I will ask the question a different way. 55 years old, presbyopia correction, reasonable expectation, everything average. What is the highest percentage lens you use?
PanOptics.
PanOptics. Francisco.
Thirdly, a trifocal IOL. More, I would say, PanOptics, or I'm finding also the Artist Symbios quite efficient by now. I like the concept of two different, energy delivery. I have to acknowledge Sheraz, who brought me to that direction. So thank you, Sheraz. And I would say that the highest percentage of my patients would have a trifocal, yes.
他们两位医生，他们的最多的病人，从百分比来说是三焦。Professor Daya, I'm sorry, Martens first and Daya.
Well, same thing. So the trifocal is the predominant one, and I'm switching between the fine vision, GF as a hydrophobic version and a Triumph, mix and matching them. The Symbios, the Artist, also thanks to Shiraz, who told me to use that lens and see what happens. And recently also the geometric from Hoya. I'm using it now in a couple of patients to see, and also very good results for the moment with that lens.
所以马天教授最大的比例用的还是三焦，从病人的百分比来说。Professor Dai, what's your highest percentage? 55 years of presbyopia.
Okay, so 95% of my patients will get a trifocal, and it's one of three. It's either the Physiol Fine Vision, which I use more of, the Artist Symbios, which my colleagues have discussed, or the Zeiss. Now, how do I differentiate between these? It depends on whether they are myopic, because certain lenses fit better and don't rotate if they're toric, and also what their near vision requirements are. So I'm taking one step further. I don't even bother with EDOF or increased range of focus lenses, because that's not what my patients want. They want everything. And if they work up very close, then they will get a specific lens for that purpose. But it's still a trifocal. It's still a full range of focus, but more, again, further designed for them. And it all depends not just on the lens, but their cornea, their corneal aberrations, their axial length, and their mindset.
大家他的最多的病人也是三焦晶体。李教授，你的回答呢？
Yeah, trifocal. I transfer from laser Zeiss laser trifocal to PanOptics now, because PCU is too high for Zeiss trifocal laser.
是李教授的也是三焦。马教授。
First, of course, it's trifocal for the proper candidates. But for some patients, young, as you said, is 55 years old, and they have a large kappa angle or alpha angle. Sometimes I choose the Oculantis Plus because it's asymmetrical segmented. But from the slide presentation of previous expert, they deny that kind of lens. I don't know why, calcification or some bad performance. As for my experience, I use that for 5 years. Some of my patients, they are okay with that up to 5 years old. 5 years now, the Oculantis lens. It's okay with the bigger kappa angle or alpha angles.
所以马教授的最多的病人也是三焦。But the spirit of today's presentations spoke by everyone is customization, and that is the most important. 每个病人的选择不一样。My second question I will open to the audience is, among your lens surgeries, intraocular lens surgeries, what percent are RLEs, purely elective lens surgeries for presbyopia correction? What percentage your intraocular lens surgeries let's go only include pseudophakic, not ICL phakic, cataract surgeries. Arthur, what percentage are ILE pseudophakic setting? What percentage resulting pseudophakic? What percentages are cataract?
Ming, I'll give you two answers quickly. The one is 5 years ago, it would have been 20% RLE, 80% cataract. Today, it's 40% RLE, 60% cataract. So despite the fact that cataracts are growing, RLE is growing even quicker, even faster. I'm not sure there's permission or the regulations allow this in China, so you need to make sure about it locally. But certainly where we can do RLE, it's growing quicker than cataract surgery.
我第二个问题就是说，在做晶体，就是这个 pseudophakic 不包括 ICL， 那个哪个百分比是就是说这个晶体置换完全是选择性的，而且跟那个白内障晶体手术比，阿瑟教授说5年以前他20%是晶体置换，今天他40%是晶体置换，剩下60%是白内障手术。Professor Martens, what percentage among your intraocular surgery, excluding ICL, are ILE versus cataract surgery today?
Yes. Well, we have a particular setting here in my practice because I do 2/3 of the RLE and 1/3 cataract. With my colleague, my younger colleague, he's doing 2/3 cataract and 1/3 RLE. So it depends on your mindset as well as a cataract surgeon. And also, most of the patients, I'm known for getting rid of contact lenses and glasses and doing surgery for that. So a lot of patients ask for a consultation with me, whether the normal consultation with cataracts flows more to my partner. So it's we divide them between us. So it's not a fixed number here in my practice.
马坦教授跟他的这个 partner， 但他们大概是1/3到2/3，大概平均是一半。Professor Coronas, percentage ILE versus cataract.
I want to say 66 RLE, 33 cataract surgery. But I want to define this a little bit better because we are talking more and more with the patients about dysfunctional lens syndrome, which does not necessarily mean cataract, and it does not necessarily mean refractive lens exchange. And this is a concept that patients really like a lot. Again, we know that it is a refractive procedure in this case, but the fact that you are counseling it as to counteract a dysfunction of the lens makes all the conversation with the patients much easier.
Corona 教授他是差不多60%是 RLE 晶体置换，他同时也是开始教育病人，就是晶体老化还没成为白内障的这么一个现象，逐步让病人意识到。Professor Daya.
So it really depends what you define as a cataract, as has already been alluded to. So we have clear guidelines here in the UK, and that's 6/12 or 20/40 vision and less is a cataract. So if we use that criteria, then 1/3 of my patients are cataract and the rest are refractive lens exchange. But so many of my patients who are under the RLE category actually do have some dysfunction from cataract.
大亚教授2/3是晶体置换，1/3他的晶体手术白内障。李教授
Yeah, I have about 20% clear lens extraction for patients, and this including 10% for presbyopia myopia and 10% is for high myopia. Another 80% patients for cataract, but most of them have a problem of refractive problem. So not only cataract, so they want to resolve their refractive problem.
李教授，你自己翻译吧。
他就说我们20%是单纯的透明晶体置换和多焦晶体植入，但是其中呢一半是老花的，一半是高度近视的。这80%的这个白内障里边， 这个多节晶体植入的呢，实际上也不是单纯是白内障，其中有好多还是有这个屈光问题，它要解决屈光问题的啊，两个眼的这个屈光参差或者是一些晶体硬化了，出现一些其他的问题啊，所以不是单纯的白内障。
马教授，中英文，您的 answer 呢？
其实，在我们院跟李教授差不多，我们这单纯的晶体置换真的没有那么高的比率，尤其是正视眼的透明晶体置换几乎是没有，像我们有20%的透明晶体置换，但大部分是高度近视或者是远视。我们就是他主诉来了，是他自己觉得视力下降了，我们一查是他有那个近视或者远视的发展，其实是一种早期的晶体施工，但是真正的就是因为老视，我就敢做晶体置换的还是很少很少。
这个是大概中国和世界的一个差别吧，就是咱们世界的专家来说，晶体置换治疗老花，它的比例跟整个晶体，包括白内障里面比例比咱们中国高，这个也是世界现在发展的方向，就晶体置换来治疗老花的比例越来越大。在美国爱尔，我们也是在世界这么一个范围内，也是跟这些国际专家差不多。总的来说，比中国的比例大一点。我想中国也是会往那个方向发展。小沈，我们大概能够回答1-2个问题，您能不能读一个问题给我？
好嘞。王医生，我这边先读2个中文的问题给到您。第一个问题呢，就是说近视患者植入功能性人工晶体之后满意度比较低，尤其是看近这个不是特别满意，有没有什么好的解决办法？这是第一个问题。
好。The question is, for myopic patient, is actually more challenging for this presbyopia AT-IOLs, in particular, preoperatively, let's say someone who's -5, they actually have beautiful near vision pre-op. How do you deal with these challenges? We start with Arthur.
Yeah, that's a really good question and a very good point. This is all about informed consent. You have to explain to the patient that they're going to lose some level of near compared to what they used to have, but they'll have functional near. And for me, it's the most difficult group of patients for AT-IOLs. The hyperopes are the easiest, and that's why it's a good place to start. But informed consent and showing them what it would look like if both eyes were corrected fully and have no reading. They need to see what the extremes are, what they currently have, what they would have without any AT-IOL, and then give them an idea through a phoropter of what they would have with a +2.
Arthur 教授说这个问题非常好。这个从近视术前近视这个方面，从 AT-IOL 这个功能性人工晶体，这是确实是最大有挑战的。在有些病人确实他们的近的视力呢会有减低的。当然来说，我们知道远视的病人那是最容易做的，所以这方面要跟病人好好讨论。下一个问题，小沈读一下。
是否可以请各位专家，然后介绍一下 EVO-ICL 在治疗老视方面的效果、临床效果
？Second question is EVO-ICL in treating presbyopia. I believe who spoke about that again?
Professor Martin.
Yeah, Professor Martin. Yes, please.
Yes, what do you want to know? Because it's
what is your clinical result, impression of using EVO Viva in terms of treating presbyopia in the phakic setting? What has your been? Let's say, let me ask this question: if someone who comes with classic profile of presbyopia correction, let's say 50 years old, would you go for EVO Viva, or you go for lens exchange?
Yeah. Well, that depends, of course. First of all, what is the expectation of the patient? How do the crystalline lenses look like? Are they beginning cataracts or not, and so on. On top of that, the ICL Viva is only available in for myopes. So you can only treat myopes and use them, of course, with an acceptable anterior chamber depth of 2.8 millimeters or larger. Then it depends again. So we're just starting to explore the possibilities of these lenses. As I told you, I was one of the participants of the European multi-center study, and there was a very, very strict protocol where we could not do anything outside that range. So we're now implanting lenses in a larger population group, and also experimenting with one eye, so the dominant distance eye, the sensory distance eye, we put in a normal ICL, and in the other eye we put in the Viva. So we're just learning what is the best way to use these lenses, because it's a completely new area we're just exploring, and we are putting together a playbook. The plan is that STAR Surgical will release these lenses in a broader way to other ophthalmologists by ESCRS. So in August this year, this will be available for more surgeons worldwide. But meanwhile, we're still finding out the best indications in which patients we can use these lenses, and in one eye, in both eyes, and so on.
他们现在这方面还在继续做 research， 而且这个 AT-IOL 的话只是适用于近视的病人，所以在目前来说还在进一步发展，逐步看。因为今天咱们有很多观众，所以呢，非常感谢大家来参加，所以呢，稍微延迟几分钟，给每个专家能够有机会回答一个问题。小沈，下一个问题。
张耀，你那边有没有收集到一些问题，也可以来提一下。
如果你在收集的话，我来问一下这个Professor Caron's question for you. In UK, RLE is complete self-pay. Is that correct? And that does how do you overcome that significant barrier to be able to have the percentage of RLE? 我的 question 给 Caron 教授说，在 UK 在英国，晶体置换还是完全自费的，你怎么能达到比较高的百分比？
Well, I'm answering for Italy, and I think Shiraz may answer.
I'm sorry, I got confused.
But that's okay. But I think that this is going to be pretty much the same. In Italy, all presbyopia correcting IOLs are delivered on a self-payment basis. So they are not reimbursed by the National Health Institute at all. So if it doesn't really matter if it is for cataract or for a refractive lens replacement. So it's a pure like refractive procedure like LASIK, and patients have to pay for it.
他的答案就是说，如果是 AT-IOL， 如果是功能性人工晶体，不管是白内障还是 RLE， 晶体置换都是要自费的。Well, the two doctor truly from UK, Dr. Daya, what's your answer to that?
So we are completely in private practice, so even our cataract patients will be self-pay in the majority of cases. So the last time I checked, less than 30% of our patients are on insurance that come to me, and one by one, the insurance companies don't want to pay me my rate, so I'm being taken off them. So almost all, it's getting to the stage where almost all the patients come to see me in particular will be self-pay. And we, as I say, we pushed ourselves to be a completely premium practice where we give patients a high level of vision correction, full range of focus, and look after them very well afterwards as well. So that's the way it's going. I think it'll be even more so in terms of self-pay. But there are a group of people in this country who can afford that level of payment for this type of surgery.
Thank you. 他说这就全是自费的。李教授，你的RLE 病人是两个眼睛同时一天做呢，还是像白内障不同一天做 ？Professor Lee, do you perform RLE bilateral on the same day, or or like cataract surgery on different day?
肯定是分开做啊，这个一天做肯定是有风险，两个风险，一个就是可能同时感染的风险，第二个呢就是我们要术后 因为这个多节晶体这个测算精确度非常重要，我们术后看它测算的第一只眼测算的准确度，人工晶体度数。如果是住3天到1周以后呢，稍微稳定一下，如果它有什么小的误差，我们另一只眼睛可以再调整这个度数，这是非常重要的，所以我们分开做。
Can you translate?
Yeah, you translate please.
Oh, you want me to translate? Okay. Professor Lee feels that he wants to, he always does on separate days, even for ILE. He wants to monitor refractive outcome so he can adjust for the second eye. And the last question for today for Professor Ma, what percentage of your AT-IOL patients require refractive corneal enhancement? 你的AT-IOL 功能性人工晶体病人里面，你们高端做比较多，需要做屈光那个角膜手术 enhancement 的百分比是多少？
To tell the truth, none up to now, because the previous pre-op biometry is very important. So up to now, no need of the enhancement refractive surgery.
How long you been performing for many years, isn't it? So
Yeah. But in IR hospital, none up to now. 2 years for Shenyang hospital. Yeah.
I think yes. I think
one more question. Yeah. Because with explanation or something, just okay. No need of that laser refractive enhancement.
It's interesting. That's amazing. But I would say, assuming that we all do the best job, biometry and everything, Professor Ma, your team is doing an excellent job in patient expectation setting. I have to say.
That's important.
We in a different session, we love to learn some of your tricks. I would love to have 0% also, which is for us, our USA is not 0%. And I think it's expectation setting. So I would like to summarize what we have learned from the international experts. I'd like to summarize. Yes?
I got one more question from foreign audience.
Okay,
so let me
go ahead.
This question is to all our experts. The question is, can be EDOF IOL consider a multifocal lens? Thank you.
Arthur?
I think Sheraton answered that. He's doing a thing for ACOS looking at the classification of lenses. But yeah, the EDOF lenses are multifocal. Some work on a different principle. But the point is they're giving us focus at more than just distance. So they are multifocal, but as Shiraz says, and I like his classification, it's a limited range of focus versus a full range of focus. It's an extended range of focus. So I think what will happen in time as we get to better classifications that make more sense for doctors and patients, that's going to be a nice step forward.
Thank you. 现在已经10分钟超过了，我们非常作为爱尔。咱们眼科，大家都知道，爱尔是世界上最大的眼科集团。我们有600-700个中心，中国现在500-600个中心了吧？那欧洲有85个，东南亚11个，香港7个，美国1个。所以呢，是世界上最大的眼科中心，而且呢，覆盖面积是这个也非常骄傲，在世界最大的眼科中心在中国，我们爱尔因为是世界上最大的，而且有3大洲，我们就有这个能力，能够把世界最顶尖的，包括咱们国内最顶尖的专家们请到一起，能够共同探讨共同研究，给我们病人带来最好的治疗效果。这是咱们爱尔非常独特的，也就基本上也是世界上也仅有的这么一个眼科集团，在这么一个平台上。所以今天大家得到了一个体验，我们得到这个分享和智慧和学习，世界上最好的专家。AIR is the world's largest ophthalmology group with 700 locations now, with 600 in China, with 85 in Europe, 11 in Southeast Asia, and 7 in Hong Kong, and 1 in the United States. covering 3 continents and servicing 2 billion. There, as world's largest ophthalmology group, has the ability to be able to, such as we have experienced today, invite some of the top specialists in the world and to learn their thinking process and the technology and their approaches to generate the best patient outcome, and also include our own top experts such as Professor Lee and Professor Ma. And that's a unique feature of our group, and we will continue take advantage of that platform and to be able to share wisdom on the world stage. 今天3个最重要的 take home message， 如果咱们医生做笔记的话，就这3点要回去要想想。第一点，病人要 customize， 要必须每个病人他的要求不一样，要搞清楚他的工作、他的需求，以及跟这个晶体的 match， 它的对称。3 take-home message today. The first is customization of patients, and depends on the lens and the specific attributes, not just plus, but also minuses. You have to customize to each patient, their profession, their expectation, and their eye measurements. 第二个就是说这个目前这个用的最多的这个功能性人工晶体是3焦晶体。Second take-home message is biggest percentage of utilization by the international and our eye experts domestically is trifocal, even though many other lenses are in use and customized to patients. 3焦是最多的。第3个大家要记住的就是说，现在有个世界的潮流，对于老花来说，晶体置换在没有白内障的情况下，晶体置换它的比例在越来越增加，这是世界今后发展的方向，也是咱们爱尔的医生们要多学习和来能够接近世界的水平。The third take-home message today is on the worldwide stage, there's a trend towards increasing percentage of patients in the functional IOL, the advanced technology IOL arena that are RLE, completely elective in the absence of cataract surgery. I believe that's the best marriage of corneal refractive surgery and intraocular lens surgery, and that's the direction it's going. And our world experts today, as have shown us, they are leading us in this arena, higher percentages, and certainly give us, our doctors, opportunity to learn and to catch the rest of the world in that. And on behalf of our eye hospital, its leaders, Mr. Chen, Mr. Lee, 陈总、李总，爱尔的这个领导，我代表美国爱尔这个，而且呢也很感谢咱们小沈、Chloe 和小赵他们的帮助。今天我们学到了这个功能性人工晶体一些世界最新的动向，也鼓励大家回去以后呢，通过这些经验能够更好的提高我们对病人的治疗效果，利用咱们爱尔世界最大的眼科平台来给我们病人世界最好的治疗效果和满意度。我是美国爱尔 CEO 王明旭教授。最后小沈有没有一个 closing statement 讲一下？ 谢谢。
So thanks to everyone for investing time to participate in this webinar and bring us such wonderful lectures. And I would like to take this opportunity to share news with us, with all of you. We will hold an international forum on refractive and cataract surgery on May in Shenyang. So this meeting will be held during 14 to 16 of May. So we will happy to we welcome all of you to participate in this meeting, and we will also happy to invite all of you to give us more lectures on our Air Global Vision platform. Okay. 王医生，我就是这样。我顺便跟大家说了一下，我们5月份会在沈阳举行一个白内障的国际会议。到时候呢，我们也是希望邀请在座的这些国际专家来参加我们的国际会议，并且呢，我也是同时希望邀请他们能够在我们的平台上带来更多的授课和分享。也非常感谢您今天 非常精彩的这个讲解，谢谢。
Finally, we will say something in Chinese together, all of us, and especially for international experts, repeat after me. This has to do with today's holiday. 元宵节快乐. Go ahead, Arthur. Repeat after me. 元宵节快乐. Very good.
Happy Festival Day.
Yes, you all can speak Chinese now. Congratulations. Bye bye.
Bye bye, guys. Thank
Bye
you.
bye bye.
Thank you.
Thank you.
Bye bye.
Bye.
Bye bye.
谢谢邵伟院长，谢谢马院长，也谢谢
辛苦了，
陈院
辛苦了。
谢谢林主任刘博，谢谢。
意犹未尽哈，以后多举办这样的活动。
是的，我们这次会议上线人数1000多，我觉得今天效果还蛮好的。谢谢几位专家教授花时间耽误大家过元宵节了。
人家一听李教授来，人家都来了，所以这个
是的，是的，李教授、马教授，各位教授们都是。
行，欢迎大家5月份的到沈阳来。王教授5月份到我们沈阳来哦。欢迎欢迎。
好，
林教授，
谢谢旭哥，谢谢林主任，
谢谢，拜拜，元宵节快乐，
元宵节快乐，
大家拜拜，
拜拜，谢谢，
拜拜拜拜。